I am the project officer for the Substance Use and Mental Health Services Administration's grant program on older adult behavioral health. Today's webinar is funded by SAMHSA in collaboration with the Administration on Aging. The production and hosting of the webinar is through Older Americans Behavioral Health Technical Assistance Center, which is also funded by SAMHSA. Next slide. My name is Marianne Scheinholz. I'm with SAMHSA. I want to also introduce the other federal staff person, Danielle Nelson, who's with the Administration on Aging. For the Older American Technical Assistance Center, Alex McNeil, who works with the National Council on Aging, will do a project and webinar overview. Next slide, please. I mentioned that I am the project officer for the older adult behavioral health program at SAMHSA. In 2011, SAMHSA funded a grant program which would expand on the existing older adult targeted capacity expansion program. That had been in place since 2002. The new grant program expanded to include prevention of suicide and drug use and abuse. The population of the original program and the current program is people ages 60 and older who are at risk or experiencing behavioral health problems. A lot of noise in the background. People could mute their phones. I'm collaborating on these projects with the United States Administration on Aging. AOA and SAMHSA are both under the Department of Health and Human Services. As I mentioned, this current program, which was in effect as of 2011, had 5 grantees, and they were funded up to $356,344 for 18 months. Next slide. Can I have 4, please? Programs, we have a number of people, actually from 4 of the 5 grant programs. We have the program directors who will be talking to you today about a little bit about their project and particularly about partnerships. The caveat for the current grant program was that all applicants had to identify and have a relationship with a partner in the community, and to be an aging partner. I know many of you come from aging networks, and so that's a grant requirement. They couldn't just say, we've talked to these folks. They actually had to have a partner. Let me introduce the program directors to you, and then they'll come on one at a time. Teresa Holt, who's with the Senior Reach Program at Jefferson Center for Mental Health in Jefferson County, Colorado, which is seniors preparing for rainbow years. Christopher Kerr and Ann Robeson. They are from the Montrose Counseling Center in Houston, Texas, which is the Wellness Integrated Network, with the Family Service in Los Angeles, California. And Vivian Sauer is going to be speaking from the agency. And OASIS, Older Adult Home Services, with the Oakland Family Services in Pontiac, Michigan. And Michelin Summers is the project director and will be speaking today. Next slide. And over now to Danielle.
Thank you, Marianne. On behalf of Administrator Kathy Greenlee, I would like to welcome everyone to today's webinar. I'm thrilled to be participating with our sister agency, SAMHSA, on this important initiative and look forward to continuing to provide technical assistance opportunities and tools for the Aging Network over the coming months. Please. As some may be aware, the Administration on Aging recently became part of a new agency still within the Department of Health and Human Services. It's now called the Administration for Community Living, or ACL. The goal of ACL is to increase access to community supports and participation while focusing attention and resources on the unique needs of older Americans and persons with disabilities of all ages. ACL will support policies and programs focused on the unique needs of individual groups. This includes individuals with or at risk for behavioral health issues. Next, it brought together 3 individual HS agencies into one. It is working towards improving access to person-centered services, creative efficiencies, and leverage and influence for all programs. Administration on Aging remains intact with the same programmatic focus. It just moved programs with AOA into line of business. The day-to-day management of all 3 previous agencies' programs remains relatively unchanged, with the current program staff retaining their assignments. The vision for the SAMHSA AOA collaboration very much aligns with goals of our organization, the Administration for Community Living. So with that, I'd like to pass things along now to Alex McNeil.
I'm Alex McNeil with the National Council on Aging, where I lead the behavioral health work of our organization. Slide, please. I'm going to offer a brief overview of partnerships, what some research has recently been telling us, before we get into hearing from the 4 grantees and the lessons that they've learned with partnerships. Slide. I believe that partnerships are valuable because the collaborative process brings different kinds of people and organizations together, making it possible for them to accomplish much more than they can on their own. Partnerships between behavioral health and aging services can be powerful in addressing the needs of older adults. Slide. Partnerships are crucial at every stage of evidence-based programming. Part of the planning process is identifying potential partners and forming the right partnerships to the success and sustainability of services. The benefits of partnerships or the results that can be generated from partnerships are many and varied. Through partnerships, we can see increased, more adults served, more older adults screened, thus increasing the health impact of a service. We find additional types of populations reached. We find that as more organizations partner on behavioral health work, we can decrease stigma as both the staff and the clients become familiar with the issues of behavioral health and how to address concerns can increase, especially when universal screening is used by both behavioral health and aging services. Expertise in behavioral health and aging can enhance the quality of training for services as well as the services themselves. In lead and partner organizations helps with sustainability. Partner services can further help clients. Partners can bring social services, economic support, long-term services and support, and other prevention and health services. These services bring not only the specific service for the project, but knowledge and access to additional mental health and substance abuse prevention and intervention services. Support generated through partnerships helps for future funding. Partnerships can build a foundation for health and community service integration. So the National Council on Aging conducted a study of best practices in building and maintaining partnerships. We learn what makes partnerships work and best practices. We assessed community programs that were using partners and also called on national experts to review the literature in this regard. We found 6 common themes looking for best practice in partnerships, and they are here. Partners are successful when they have common goals, when there's regular communication, when there's an agreement upon roles, and an agreement on how to assess the progress against goals. Partnerships are additionally successful when there is a full staff orientation, not only the lead office developing the partnership, but the program staff, often the financial staff, as well as support and outreach staff, and the consumers involved in the organization need orientation to the purpose of the partnership and how each can be supportive. And we know recognition is very important, both high-profile recognition as well as more so quiet recognition of partners and their support of our program. And we all, in partnership work, takes time. Slide. Colleagues of ours have recently published an article on establishing community partnerships to support late life anxiety research. The lessons that they've learned include the use and expansion of existing relationships to develop partnerships with faith-based organizations. It's important to treat community partners as individuals in that different organizations have different needs. In community partnerships, it's important to maintain ongoing communication, strong sustainability of both the partnership and the service, and continue to build reciprocal relationships. I think we hear this time and again, but in schedule, we can recognize the importance of communication and building the relationship. It allows us to take the time to do the work that's needed. Please. For a number of years, the Robert Wood Johnson Foundation has supported an effort called Mobilizing Action Toward Community Health. Robert Johnson and its grantees found that the characteristics that build and sustain partnerships have social value, that is, value beyond just that individual or for the lead organization, but it has some community value. They have common goals. Again, our rewards and incentives very explicitly spelled out from the outset, and there's a comprehensive and coordinated approach to attaining community health. Slide. The Council on Aging and others are looking at a new model of partnerships called collective impact. This model for large-scale social change uses cross-sector coordination by government, nonprofits, and business. The collective impact model was described in a recent Stanford Social Innovation Review. The features of this model include a common agenda, we hear this again, shared goals and shared measurement systems, agreeing to how to assess achievement of the goals, mutually enforcing activities, continuous communication, as well as a dedicated organization to provide the background support for the effort. As organizations seek to get in step with each other, we offer several resources. The National Council on Aging Center for Healthy Aging has a list of partnership resources, articles, tools. Please see this website for that assistance. SAMHSA's website also has many tools for partnerships. Please search for partnerships on their website. And then I'm also noting a partnership self-assessment tool right here. Now move to the 4 SAMHSA grantees to learn what they have experienced in building and maintaining partnerships. We asked each grantee to discuss very briefly their lead organization and the specific services that were funded under the SAMHSA grant. Then them to identify the needs that they decided to through partnerships, the key organizations that they have found, they've learned in developing and maintaining the partnerships, as well as the community benefits of partnerships as they experienced them. And I want to know that after 4 speakers, there will be 15 minutes for question and answer, that you type in questions to the box that you can find at the top of your screen. The webinar will be recorded, and recording and slides will be made available to those of you who have registered for the webinar. And moving to our first speaker, Teresa Legault from Colorado. Teresa?
Thank you. Thank you for joining us today. Next slide, please. Senior Reach. And Senior Reach is built, it's a program built on partnership, so it's very exciting to be part of this webinar. JFSLA Center for Mental Health is the lead agency, and they partnered with the Seniors Resource Center, which is a large metropolitan community center, and mental health partners, and collectively they provide mental health counseling, wellness services, care management, and in-home resources across 5 very diverse counties. Next to the new SAMHSA expansion funding, it has allowed us to expand services into 6 primary care offices. And expansion, as noted before, targets seniors at risk for suicide, experiencing depression, and use of alcohol or prescription drugs. Next slide, please. SEACH is built on a gatekeeper model, and this means that we train community partners, community members, our partners, to identify and refer seniors who need help, but they're not coming to the attention and ask of seniors agencies and asking for help on their own behalf. We're really excited about our new partnership with the primary care providers, which integrates behavioral health with physical health by screening seniors in a safe and trusted location, which is, of course, their doctor's office. The tools that we're using that are new to the program include SPRY, which is a screen for alcohol and prescription drug misuse. We're using a depression care management model. It's a coaching telephonic model that helps a client set self-management goals and kind of follows up with them around that. There's an increased focus on suicide prevention, and this really matches well with our gatekeeper model because it's training gatekeepers on that aspect of identifying, responding to suicidal situations. And of course, we continue our traditional Senior Reach home services, which were listed on the previous slide. Next. Are a key component of Senior Reach. We really couldn't do it alone. We needed to identify those seniors not seeking services on their own behalf, and how could we do this? Who would spread the word about our services, identify and refer these seniors? We want to educate the community on healthy aging and identifying seniors who could use help. Who would partner with that could help us along those lines? And how are we going to access these older adults? They're definitely not coming to our attention willingly. So how would we get inroads into talking to seniors in safe locations, such as senior health sites or senior apartments or doctor offices? And then, of course, we wanted to build the collaborative community fabric so that we knew what each of us were doing in our work with seniors, and we could provide better services and help identify gaps and respond to those. I'd like to note that while partnerships that I talk about today are kind of grassroots and community-based, our Agency on Aging Denver, the Regional Council of Governments, and county councils and funders are very important. But I'm not going to be focusing on those. You'll hear about those partnerships later as well. Next slide, please. So with Reach, gatekeepers are our key community partners, and we have kind of broken them up into 2 main groups. First, traditional community partners. That would be your partner with the Area on Aging, law enforcement, the folks that work with seniors daily, and they know what to do when a senior needs help. The second group is really a vital referral base for us, and that's the folks that when they see a senior who needs help, they don't know what to do with it. And so community outreach and training really networks these folks into partners in a community all working to better serve seniors. For instance, this could be the neighbor, it could be someone at the church, it could be somebody driving the Meals on Wheels van and just scratch their head and they're like, I know she needs help, what do I do? There's a lot of strength in community partnerships. For example, Senior Reach has been replicated by Mental Health Association of South Central Kansas, who also received an expansion grant but was unable to attend today as a presenter, and a program called Mid-Kansas Senior Outreach. So between Mid-Kansas Senior Outreach and Senior Reach, the outreach and training efforts have reached over 35,000 people since 2006. So it shows you, you can imagine that impact would have on reducing stigma around a senior asking for services, and particularly around seeking mental health assistance. With the expansion project, our primary part has been the primary care providers, and with the Kansas program, the Expansion Key Partners is an agency, kind of a collaborative partnership called Triad, and that is a group of folks that meet that are seniors. There are people working with seniors and law enforcement, and that's been a really good partnership for Kansas. Next, please. In developing partnerships. Needless to say, you can imagine with a gatekeeper model how many partnerships that you have that you're working with. And there are many lessons that will be pointed out. One of the important things that I learned was that you always have to keep on identifying community partners. Just because you start out the grant, you have everybody at the table, you're not done. It's important to continually evaluate, develop new partnerships, and nourish those existing partnerships. As part of that, you have to be really clear about what you can provide and what you cannot provide, and at the same time, understand your partners. What do they need from you? What can they provide, and what can't they provide? And as part of that, if you think about the value of each partnership, spend time really understanding what that partnership brings to your program, what you bring to it, and really thinking that piece through. I think one of the parts of being a partner in a group is to participate in each other's activities, attend the special events, support the fundraisers, just get in there and be involved and be active in the communities you serve. And especially in rural communities, you know, they're very closed and they don't want strangers coming in. You have to be part of the community to build the partnerships. And, you know, go ahead and staff a table at a community fair, hand out cheese at the food bank, and, you know, make a presence and be active. So next slide is on lessons on maintaining partnerships. And I have to say, one of the parts of my job I value most is maintaining and working on partnerships. As lessons learned in maintaining these, the ones that floated to the top for me was realizing how vital the partners can be as advocates for my program. You know, educate your partner on what you're doing, why you're doing what you're doing, educate them on outcomes, update them, keep them current on what's happening with your program, and provide them brochures. And it's amazing the places that advocates for our program have gone out and talked about Senior Reach that I was unaware they were even networked into, and put their services, of course, in return. I enjoy recognizing partners at every opportunity, whether it's publicly or individually. It can be as, you know, formal at a meeting, it could be an informal cup of coffee, but it's just important that it's continual and it's genuine and you do it. And in order to ensure open communication, I think the thing you need to do is listen and see what people are saying. Feel free to ask for help if you need it, and for help, you know, when it is needed. So we're doing all this good work and we're trying to balance all the balls in the air. I think it's important to have fun, and sometimes we forget that piece. And if you have fun, you're fun to be around, and work seems to be less work. So community benefits of partnerships, something I'm going to talk about. And you know, we've heard quite a bit, I think, lead up to this, and you guys could probably share many lessons with us as well. But certainly, the better use of resources and expertise is one thing that comes to mind. For example, Senior Reach staff will teach a class at a local senior center, and both agencies advertise for the class, so all of a sudden we are, reaching an audience that we hadn't been able to access before. We're getting free space at the senior center to provide a class on depression or healthy aging, and the senior center is benefiting from getting the diverse programming, not paying for the space. So the variety the class offers and the benefit to the relationship, and that is an example of how sharing resources and each other's expertise can help. Better community infrastructure to support seniors working together. If we know what each of us are doing and we're working in partnership and networking together, we can make those referrals. We can bring in resources and better serve those that are in our community. And this talking, I think, is reducing stigma. I think the more we get our outcomes out there, the more we talk to folks that aren't involved in community behavioral health, and the more they understand what our work is, and they're there when you need it. We had one of our major counties come out with a budget that didn't include any mental health support, financial support, and we put word out to community partners, and we got feedback to this agency that resulted in the budget line item being added in. So it's just, those partnerships come in and are valuable at times you would least expect. That's with building a case for services. I was talking to our editor, and one of the volunteer seniors on the panel, and I'm not sure what role he played, they asked, what partnerships do we have? How do we network in the community? And I answered the question, and then this person, who I don't know, spoke up and said, we've seen Senior Reach out there. They've done, and he told a story that was far better than anything I had said. So the partnerships really do play out for you. And of course, with especially a gatekeeper model, the case finding has been really important for us, and getting word out there. This is what's happening, and this is how you can access those services. Okay, that is my piece of this, and I thank you for listening, and I'm going to turn it over now to Chris and Ann in Montrose Counseling Center.
Thank you, Lisa. Very well said, and we could echo a lot of that. This is Ann Robinson with Chris Kerr from Montrose Counseling Center in Houston, Texas, and our program SPRY, Seniors Preparing for Radio Years, kind of a wink to the senior gay community in Houston. Our mission is to empower our community, which is primarily gay, lesbian, bisexual, transgender, or GLBT, individuals and their families, to enjoy healthier and more fulfilling lives, and do that by providing as affirming and culturally appropriate services as possible. Next slide, please. Thanks. We're a behavioral health clinic first, but we're also involved in the primary care behavioral health integration grant that SAMHSA are doing, and we've been leveraging that to work with our with this SAMHSA grant, with our SPRY grant. The services that are involved with general behavioral health services are obviously counseling, master's level clinical and PhD level clinical counseling, clinical case management, which means all of our case managers are licensed at master's level. We are a patient licensed substance abuse treatment program with extensive outreach services, and Chris will talk about the specific ones for this program, but we do a lot of HIV and substance abuse outreach. We have social and recreational services, and a lot of that is leveraged with our wellness services that we're doing under our integration grant. Chris, let's take it over to you.
Next slide, please. So the current services that we're providing under this grant to prevent elder suicide and drug abuse prevention, it started with a social media awareness campaign to try to affect the GLBT community and change both its attitudes and some some outcomes around suicide and prescription drug abuse or misuse. And to do that, we are using several evidence-based practices. We are doing adult education along with the program Get Connected, similar and mixing those a bit. And that's for the drug abuse or misuse prevention. We're also doing, for the suicide prevention, QPR, question, persuade, refer. It's a very short, at most an hour long, kind of very lay-oriented program to help people intervene and when someone is thinking or talking about suicide, and then offering them referrals effectively. And it to be done like CPR to as many people in a community as possible to change outcomes like, survival from heart attacks, or in QPR, survival from depression or suicidal thinking. And as part of that general outreach, we have volunteer outreach workers who are to go out into the community, establish relationships one-on-one and with groups, and from that use the PHQ-2, 2 questions as a screening for depression, and the CAGE-AID, which is a screening for alcohol and drug abuse. And those people who are positive for that are offered referrals into our program, and the intervention part of that program is Healthy Ideas, kind of brief intervention program that's counseling, but it's actually focused on behavioral activation. And you could probably look up just a quick Google search in any one of those if they're not familiar, and find descriptions of them as evidence-based practices. Next slide, please. Needs that we've addressed, and for us, what's really essential and important is this need for outreach. What we had discovered in a previous SAMHSA grant providing mental health services to the GLBT elder population is one, don't have a community partners, say the doctor's offices or medical centers, that have a stream of GLBT elders coming in that then we can screen and then refer into our program. You would think if you would could put a sign out in front of your agency saying, free counseling for GLBT elders, or counseling at no cost, that people would beat a path to your door. And we thought that wasn't true, that there was a lot of resistance and fear among GLBT elders in the community to come forward and to talk about the important issues of what their needs are. Remember, this is the generation of GLBT elders that grew up when it was kind of illegal to be gay, and there were lots of attached to that, lots of very real consequences. Carry that into their fear of putting themselves as they seek services. So outreach has been essential for us to go out into the community, to establish relationships with our community partners, who are mostly GLBT organizations that have long histories in the GLBT community, and often they're social organizations and kind of informal groupings like that. And doing that outreach, we're working on this hard-to-reach, marginalized, underserved, and high-risk elder population, difficult to reach, especially through the traditional mental health providers or primary care providers. Often for GLBT elders, the doctor's office probably is not considered a safe place for them, especially to out themselves. So oftentimes they're not talking about their orientation, and they're not talking about kind of feelings or things that are deep like that. They may talk about aches and pains, but not other important things, for fear of outing themselves in some way. So that was not a traditional way. So our outreach, we're using an indigenous leader model. That's we're taking peers, GLBT peers, to them, and then sending them back out into the community. Recruit them, and we were calling them advocates. They would be trained in active listening and crisis intervention, suicide prevention, and trained in how to make casual social contacts into potential helping conversations, and even possibly screening and referral. In doing this too, we found that for volunteers to do that, that was kind of intimidating. So we started with kind of a less intimidating level that we call ambassadors, which are people who are going out there to talk about our QPR and adult education, and get individuals or groups to volunteer to do those trainings and become gatekeepers for us, and also to find other people who are willing to be advocates. And part of our
and our sustainability and financing, because we use master's level clinicians, we're able to bill Medicare and Medicaid and private insurance for a number of our services, but we do have a contract with the Area Agency on Aging for Houston and Harris County to provide services for people who are between 60 and 65 and maybe are uninsured. We also have a lot of foundations and individuals in the community that really like this program. It's a very favorite. Our youth program and our senior program are favorites of community members to support. Now, the next slide, please. Our Agency on Aging has actually been very supportive. It took us a couple of years to figure out their system and to get engaged with them, but they've been very supportive of us, and they fund our mental health services, and the new part that has come out about evidence-based practices, they've encouraged and welcomed us to apply to continue our funding for our Healthy Ideas under that. We do have a partnership with a federally qualified health center under our primary care and behavioral health integration grant, and they are just a few blocks away, and we have leveraged that to help get our consumers that we bring in into psychiatry and into primary care if they don't have a primary care provider. So that's been essential to that. Find that sometimes people, when they're depressed, they don't take care of their physical well-being as well. And then Chris said there are consumer organizations in the community. One is called Lesbians Over Age 50, and it's a group that is exactly what it says it is. Timers, which is a group of senior men who have social events, and Four Seasons, which is another group of men that meets every quarter and has a party. Now, we found that the women are much more interested in engaging with us in the community. The men just fun, and that's been a big challenge, but that is why we have our outreach workers to work on that. Okay, next slide.
The lesson that we've been learning in developing these relationships, we can't underestimate the need to establish trust. And for this GLBT elder population, if you are considering reaching out to that population or another hard-to-reach population, establishing trust, and very much with kind of a peer outreach program or something that really addresses kind of one-on-one people's issue fears and then eventually introduces them into the services. We are lucky here at the Counseling Center because we have a long track record of working with the GLBT population. We've been here since 1978. We have a good record of being confidential, being involved in helping in different ways, and a pretty successful word-of-mouth kind of campaign. A lot of our counseling referrals already across the age spectrum from the LGBT community comes through word of mouth of people talking about finding a place where they were safe to be themselves and able to talk about all of their issues. I still found that we had to listen to the community, even if we thought we were already, experts on that field being here. And for example, this is a little anecdote, but when we were devising the name of our program, we did a focus group, and the seniors told us that if you're going to call this program anything, it can't mention mental health or counseling. It also shouldn't say anything about gay. So, but it needs a code word so that gay elders could actually recognize that that's probably a gay program. So they came up with the word SPRY, which stands for Seniors Preparing for Rainbow Years. So there's no thing there. And rainbow, they thought would be a good enough code word and a kind of a safe word that they could come and do that without necessarily outing themselves by talking about that program. But also, for example, too, what we found in terms of our support groups, the men and women really wanted separate groups. Our peer counselors, the first peer counselors we've had were a male and female who we trained as peer counselors, and the women said they really didn't want the man in the male counselor in the group. So we have kept those segregated groups as part of listening to what they would be willing to participate in. The pitfalls we found in working with these social groups and these kind of non-professional groups is that they have their ups and downs. With the men group, there's been some leadership changes, and so for us that ends up losing continuity, and we have to start over, kind of patiently developing a trust relationship with the new leadership. Next, please.
Yeah. Some of the lessons learned is that, you know, if we want something from them, we've got to offer something. And so we have a big new building with meeting space on the first floor and storage space. And so we offered the group that were helping us, they get reduced fees or free meeting space, and they get to store their stuff here for the meeting. And we're also negotiating with the women's group, with Loaf, about moving their library, their very, very extensive library of women's books here to become a lending library for the women. We also have had some of them be advisors to our group, and we took two of the women with us to the grantee meeting in Bethesda to tell their story, and they agreed to go on a trip, but they were also very helpful to us in helping spread the word about what we're doing and sharing their message. Try to recognize people at high-profile events. We make, you know, give them awards. We thank them when it's appropriate to do that, and it's not breaching confidentiality. And then something clever I thought we did was Southwest Airlines is one of our sponsors, and they give us a number of free airline tickets every year to, as we need to in fundraising and in training and that sort of thing. And so we set aside 5 airline tickets for people who would agree to be ambassadors for us, that they're entered into advance. I mean, there's only 15 of them, so they have a 1 in 3 chance of getting a free airline ticket. Next slide, please.
And a benefit I think that's been held there is people from those different social groups have come into our support groups. A very large number of them come into our support groups or taken advantage of case management or counseling, and then they go back and tell their friends or talk about it and say, actually, you know, our working with Montrose Counseling Center has given us access to these programs at no charge, and it's helping me. That is a bit that they spread, and then more people come, and then go back and tell more people. So it really is kind of spreading out exponentially from there. So we end up reaching the broader population kind of through one group or through those individual words of mouth. So again, we can't overestimate or stress that if you're trying to reach a hard-to-reach kind of hidden or resistant population, the peer outreach program has been essential for us in establishing that patient trust, one group at a time, one people at a time. We've been trying to address all of their initial resistances, both to counseling and saying, you know, I'm not crazy, I don't need counseling, and counseling didn't work when I was a kid, when they gave me all this medication or shock therapy, how can you help now? And address those needs patiently, or those questions. So the fear that if I come in, and this is a federal program, the federal government will know I'm gay, and then something bad's going to happen, and letting them teaching them, and establishing the confidentiality that we have, and letting word of mouth spread that they really do keep our information confidential. And we build services with them, and then they come back and tell us more what they need. One feedback that they gave us is, besides kind of formal counseling, there's just a need for more social programs. And we've been working with them and learning that actually social programs, they can be portals into the service. That once they've come and said, you know, we're not deans, then maybe they'll come in and seek services, or it's not so threatening. But also the social programs can be therapeutic in and of themselves, and maybe enough for some people what they actually need. I think we have our time in maybe a few more minutes, so we will turn this over now to Vivian in Los Angeles for her presentation.
Thank you so much. We're very happy to be participating in a webinar on such a critical topic. Next slide, please. Jewish Family Service of LA is a non-sectarian agency. We serve individuals and families of all ages, with a very heavy concentration of our services are devoted to the older adult population. Our previous SAMHSA funding really allowed us to integrate our traditional social services with recently acquired evidence-based mental health practices. Some of our core services are listed on the slide, but more and more we're actually finding that we're focusing on health and behavioral health services really for all ages. Next slide, please. Our program is called WIN, or Wellness Integrated Network. Like the other grantees, we're providing both screening and intervention. For the potential alcohol and medication misuse, we're providing the SPRY screening and the BRIGHT tool as an intervention. For suicide prevention, we're particularly focused on getting through the PHQ-9, and particularly on question 9 of the PH9. And similarly for depression, we do PHQ-9 screening, and the preferred intervention that we're using is problem-solving therapy as our evidence-based intervention. I listed engagement. I mentioned that even though it's not an actual intervention, we found this to be a very effective tool in identifying older adults who need mental health intervention. Outreach is conducted in ways that really educate in a very culturally sensitive way, because we're dealing with several cultural communities. It's non-threatening, it's in familiar community venues, and as a result, we are really seeing a lot more acceptance in the different culturally diverse communities that we serve. So even though it's not an actual service, it's a way we're providing intervention that's been particularly successful for us. Next slide, please. So the needs that we see for partnerships and why we're so focused on it, obviously, like everybody else, we've had to expand our service network, because one of our goals is really to reach as many seniors as we can, and the partnerships help with raising awareness on a much more community-wide level. The integration of primary behavioral health care, this national trend, which we're all seeing, is a very strategic issue for us. It also speaks to some of our sustainability issues. In Colorado, we're also on site at FQHCs as well as hospitals, and this has really opened for us some new screen venues where we've never been before. It's helped to strengthen existing partnerships, and these partnerships we feel are critical now and will be critical in the future for us as well. Another need that we've seen in LA is to break down the silos, to integrate the aging delivery system and the mental health system. These are two large funding streams for older adults in LA, one through the area agencies on aging and one through the Department of Mental Health. And there is actually a growing recognition that there is a need for some level of integration, and this integration didn't exist previously. We find that the clients cross over systems, they're the same clients, or benefit from the services that each system provides. So having that partnership really helps with breaking down those silos. And obviously, we do hope that the right partnerships lead to sustainability and to continued funding for these critical services. Next slide, please. Partner organizations that we're involved with for this particular partnership, hospitals and community health care partners. These are newer partners, and again, they enable us to be on-site and expand our reach to different communities, different language groups, and that's been very helpful for us. Our Department of Mental Health has been a very critical and a very active partner, both in funding and in sustainability of some of the services we started under our previous SAMHSA grant. Fortunately, SAMHSA priorities parallel some of the department's priorities, and this really has worked to our advantage and opened up a really good dialogue for us. And obviously our area agency on aging, in LA there are actually two area agencies on aging, one for the city and one for the county. Both of them are partners in this project. Again, this opens up opportunities with the entire Department of Aging and community service provider network. There are a lot of local agencies and senior centers that belong to those particular networks. Next slide, please. So what have we do in developing these partnerships? We built on our current relationships. We've been part of some of these networks for many years. It has given us really the credibility to leverage these relationships with other entities that are newer for us. Sometimes we find that we really need to be a little bit more proactive about sitting at different tables and not just the usual traditional ones, so they can actually listen listen for the new partnership opportunities, and this has been particularly helpful with the healthcare entities. We've tried to be, again, proactive in building new relationships in the healthcare environment. We've been looking at where our agency might need to focus in the future, and some of this has driven some of the relationship building and paving the way for some collaborations that we actually are engaged in now that we've not been engaged in before. As others have mentioned, obviously it's not only about how our partners can help us work, but how we can help them by sharing expertise and helping the whole system be more cost effective. In our relationship with the hospitals, that we've had to demonstrate to them that partnering will help derive a financial benefit for themselves. And we all have learned to formalize the relationship in writing. It really enables both parties to understand their respective roles, and you can always refer back to the written document. Just clarifies things for people a little bit more, makes it a little bit more formal. Next slide, please. So in maintaining partnerships, what we find is what everybody finds: relationship. It's no different than in other areas. Really respecting the contribution that each party makes, finding that these relationships take an investment of time and energy. They can't just be relationships on paper. And again, what's been critical for us has been making the time to seek out different partners, to attend networking meetings, as Teresa pointed out. And partners really appreciate when you take the time to attend their events and you're sitting at the table with them. If you can seek funding together, it's a really useful way to bond, and it creates a win-win situation. We've been able to do that. We've been able to write grants with or on behalf of some other of our partners. We also find that we've had to learn each other's language. Our experience, for example, with our developing healthcare partnerships has demonstrated to us that sometimes our language, even though we're saying the same words, really has different meaning in each system, and it's been a learning process. For instance, if you use the word management in social services, it means one thing. In healthcare, it means something else. It took us a while to get that. We've also learned that it's not always the top person within the partner organization who will be the critical partner. It might be a senior manager, it might be a middle manager, somebody who has the time and the interest and who actually has the clients on the ground. We've had to identify, you get the buy-in from the top, but sometimes it's helpful to work with people who are not, quite busy. Next slide, please. Next slide. Thanks. And finally, the community benefits. It's a very big city, so we have to take it in small bites. And we've been able to reach additional populations who have previously had very limited access to mental health services through both our own engagement and the engagements of the partners. It's exciting for us to see the potential for systemic change. And we are seeing that in areas where we're working. It's also led us to really understand how the need for research partnerships to get hard data which will drive that systemic change is becoming more and more important for us. And we've been seeing out some of those research partnerships, which is probably a topic for a different webinar. Sharing best practices with our partners, providing the actual interventions, or helping others get trained, raising the awareness of the value of evidence-based practice, and everybody's talking about it now. So it's not only one system or the other, but everybody's talking about the need for, and they're looking at the same evidence-based practices. And finally, breaking down those silos, and this has been a particularly important goal for us. We have a much greater understanding that in both aging and the mental health systems, we're really dealing with the same older adult community who have some of the same issues. There has been a greater willingness to develop joint programs. There are some that they're engaged in now, and to integrate more services in community settings, and this has really been a bonus for us and very gratifying. So Thank you for listening, and I'm going to turn this over to Micheline.
Thank you, Vian. Good afternoon, everyone. The slide, please. A little bit about Oakland Family Services. First of all, we're a 501c3, and we recently celebrated 90 years of service in the community. We're a licensed mental health and substance abuse treatment center, and we have 3 specialty programs. One is for women, one is for adolescents, and the other is for older adults. We're a licensed foster care and adoption agency. We have a children's early learning center, preschool and daycare, and we utilize the services of older adults as volunteers in our daycare. We have a specialized services for youth. It's a contract with our local community mental health authority to provide intensive treatment for families with child or adolescents suffering from emotional and behavioral stress. And we're accredited by the Council on Accreditation and NACI, which is the National Association for the Education of Young Children. Please. Our first round of funding for older adult specialty in-home services has allowed us to provide education on alcohol and prescription misuse to our client base, as well as treatment for depression, anxiety, and substance abuse and misuse. Our program is based on a community outreach model. We provide these services here in our office, out in the community, and also in the client's home. And we're providing education on suicide prevention, not only our clients, but to older adult service providers as well. We're working with local hospital emergency room staff and our area agency to help them develop awareness about suicidal risk factors when working with their older adult clients. Next slide, please. In developing our program, we addressed partnering with key community service providers, looking at their capacity for outreach. In other words, how many isolated older adults did they have access to promote the availability of the OASIS program? We knew we wouldn't be able to reach every person in the communities who wanted or could benefit from our program, so we needed for our partners to be able to have that capacity to market for us as well. And although we've provided older adult services for over 20 years, we wanted to have partners with the latest information on community resources available for us to serve our clients. It never ceases to amaze me when I hear about a wonderful program and it's been the best kept secret, and I didn't want OASIS to be a best kept secret. Next, please. We decided that the most advantageous relationships would be with those who most often touch the lives of isolated, homebound older adults. So we worked with 2 local senior centers that provide over 25,000 homebound meals annually in 13 communities, and had already developed a reciprocal relationship with them over the years. We did training to their meal delivery drivers on identifying symptoms of depression, anxiety, or substance abuse, and they in turn would inform their supervisor when they thought that they saw or recognized those symptoms in their clients. And the supervisor would call and ask if they would be open to having someone come out to talk with them from the OASIS program. Partners that we utilized were 2 local health systems. One of our local health systems recently opened specialized senior emergency rooms in several of their hospitals, and we were fortunate to have one of them right in our own backyard. The hospital system has a geriatric clinic where families in this area often take an older adult at the first signs of memory problems to be evaluated. And they've been a significant referral source, not only when they identify depression, but when they have early-stage dementia clients. We closely through networking groups where we met older adult service providers from every discipline, and we had our 30-second elevator speech prepared on what we could do for them. They've taken advantage of our educational programs either for their own staff or they have volunteered to sponsor us in older adult communities so we could get the word out. We work with our local area agency to train their contracted service providers and case managers and have been a part of their mandatory quarterly trainings. Next slide, please. We all recognize that it's like everyone else, that it's not just about receiving referrals from our partners, but also providing them to them. So when they have a client in their office who's crying about family issues or aging concerns or is unmotivated for treatment, and just not sure what to do with that client, they can call us and reach a live person to respond to their concerns. Similarly, when we run across someone who needs a caregiver, meals, transportation, help with their Medicare or prescriptions, we know who to call as well. It's important to know what our partners need so that we can refer to them and to let others know about them in the community. Memorandums of agreement have been extremely beneficial because they not only help develop a formalized relationship, but they have very clear criteria on what you will each be doing for each other. Next slide, please. We shared our data with everyone that we could and at every chance that we had so that our partners were savvy about the mental health needs of older adults and so aware of the benefits of treatment. Our goals were to improve the recognition and understanding of depression, anxiety, and substance misuse symptoms, not only with older adults, but with the entire community that provided services to them. We want to reduce barriers to treatment for the older adult by meeting them where they were, in home if necessary. We originally anticipated about 350 referrals over the life of the program, and we actually received over 700. From this experience, we also expected that only half would engage in treatment, but that was it actually rose to 70% by our second year. I believe that, particularly due to our continued efforts in talking about the benefits of treatment, also the word of mouth from those who successfully completed our program. We sent out flyers in every meeting that went out in the community several times that asked, "How are you feeling lately? Would you like someone to come and talk with you?" And wanted to improve, obviously, the symptomatology of our clients. And so to measure that progress, we used the geriatric depression scale, and our clients improved an average of 4.5 points. And also the global assessment of functioning score, and they improved anywhere from 5 to 15 points. We all asked the persons who were using our services, whether they were a consumer or a referral source, if they would become advisors to our project. And their input has been invaluable in the development and growth of the program. Recognizing our partners at any venue we participated in brought them not only recognition that they deserve, but it really helped create some friendly competition that other providers wanted to participate in. These partners have offered their written support as we sought out other funding opportunities. Next slide, please. Finally, we taught our partners about mental health and substance abuse treatment and an impact it was having on their clients, whether they were at a senior center participating in activities or increasing their motivation to be compliant with their health care treatment plan. We believe that we're having an impact on the stigma of mental health treatment, and our partners have begun to recognize the benefits of behavioral health treatment and think of us when other funding opportunities come up. We're currently partnering with our local area agency on a CMS demonstration project to reduce the recidivism rate for hospitalizations of Medicare recipients through healthcare coaching and with the behavioral health coaches. Part of our sustainability plan was to build for services in the provision of treatment. We began to provide our services on site at the original partner senior centers, not only for the convenience of the client, but to maximize the therapist's time and reduce travel, which is not reimbursable. This started out as a 2-hour block of time for walk-ins once a month and is an 8-hour day once a week with back-to-back appointments. We have begun this service at 5 other locations, and now as word of the benefits is getting out, their own communication networks, they are contacting us to implement the service at their sites. We still have lots of room for growth as we have 37 senior centers in our county. So we feel that we've been able to address not only the stigma of mental health, but provide the service in a consumer-friendly atmosphere and have begun being reimbursed for our services, which is the best of all worlds. Thank you for your interest in our programs, and I will turn it back over to Alex.
Thank you very much, Micheline, and thank you all to the speakers. It's so rewarding to the partnership and learn about the exciting work that's going on, not only that it can go on, but that is going on. We have questions about questions, and we've received a few more questions, so I'm just going to suggest that for you to offer us a question, please move your cursor to the green bar at the top of your screen. It's viewing Alicia Phillips at the top. When you touch it, a brown box will come down, and click on chat, and simply type your question into that box, and we will get the question, and very shortly we will start answering those questions. We have learned many things from the SAMHSA grantee organizations that have presented this afternoon. Some of the key lessons we've learned about developing and maintaining partnerships include understanding partner needs, building trust and reciprocal relationships, listening and responding to partner needs, whether exactly on target for what the lead organization is doing or not, use memorandum of agreement, share aggregate client impact data to show results. I think we've heard and we've learned from other partnerships as well that when all of the partners in the community can see the full impact that's being brought out because the partners are working together to implement evidence-based programming, it's been very encouraging to continue on to bring more people into the service. That genuinely recognizing partners and their work is very important, and that leveraging additional shared funding is very helpful. In the Department of Partner results, we've about the outstanding results the grantee organizations have secured. The partnerships result in health and aging services reaching more older people, extend new populations. We've heard of marginalized people who are initially resistant receive because of the partnership. We've also partnerships can result in aging, behavioral health, and primary health care services and move towards integration, and that communities are needing improved infrastructure to support and serve older people. I'm going to move it to Kathleen Cameron with JS International, managing this webinar, and will handle the question and answer period. Kathleen.
Good afternoon, everyone. Yes, we do have a couple of questions, but first I wanted to let everyone know once again that everyone who registered for this webinar will receive an email message with the PowerPoint slides as well as a recording of this webinar. Thank you. The first question is, Jewish Family Services of Los Angeles secure a relationship with or a partnership with hospitals?
Okay, I will try to think back. We actually, it started when the Affordable Care Act came out, and we realized that more and more we're going to be needing to get into the arena of healthcare for sustainability, not only for some of our services, but our clients are going to be having to deal with new systems. And in order to be there to support our clients, we really needed to learn about healthcare partnerships and partner in a better way. They weren't our traditional partners. Our traditional partners were more, social service and mental health. So I think it started, really 2 years ago. And we really did look for the opportunities for QHCs and hospitals who are engaged with CMS in thinking about deal with their older adults, and we really needed to drive the point home to them that by partnering, we're able to help keep people in the community, and that's been our major thrust with all of our healthcare partners. We have the knowledge and expertise to keep people in the community and to avoid hospitals or nursing home placement. So I think that's really been our way in, and we continuing to explore those.
Vivian. Our second question is for Montrose in Texas, and the question is about how many folks have you reached in your grant cycle? Maybe talk about the different grant cycles and how many people you've reached in each.
Well, that's a moving target. In our first grant cycle, we did a needs assessment with over 300 GLB seniors, and then we have provided mental health services to 200, and then over the period 2005 until now. And the ideas, which is kind of the point or the evidence-based practice of this grant cycle, I believe we've served about 10. And again, very difficult bringing people in, very difficult to get them to localize their problems around health or substance misuse. But the people that we have worked with, we've seen real market change, and the behavioral activation part of, which is basically what the ideas is, has really done a lot to get them in the community less depressed, engaged in a support group, and stabilized.
We have more numbers in contact with people in our QPR training. That's going beyond that. And I think one of the things that we found in the interest of sustainability for this particular grant cycle, we are trying to work with volunteer outreach, peer outreach workers. In the pre-grant cycle, we were able to hire part-time outreach workers, and that's been the learning curve for us, is working with volunteers to motivate them to do the level of work and training that's needed to do this kind of outreach work. So we're off the seat of working with paid people with the sustainability over the long term by cultivating volunteers. And I'll try.
Thank you. Thanks, Nan. The next question I think may be addressed best to Teresa and Corrado, but others can answer the question as well. How are client confidentiality rules observed when using outreach workers?
Do we know if that question's pertaining to, or not using the outreach that I'm referring to is going out and talking to folks about how to help a senior in need and provide services like that. And that's the same model that the gatekeeper model that Kansas is using. So we're not talking about any individual data with that. So I'm not sure I'm understanding the question exactly. But the outreach is considered training. It's just going in and networking with folks and saying, these are the things you need to be concerned of. These are natural aging things you don't need to be concerned of. About if there are some issues, here's one number you can call to access all these services. So I'm not sure if I'm understanding the question correctly.
This is Chris in Houston. That might be directed to us since we're using outreach workers in part of our screening. The training program for our outreach workers does stress the confidentiality aspects of it, since that are pertaining to us as a mental health services organization. So they're required to maintain confidentiality. It's a bit fluid in being a peer, so they are going to be going out to groups where they might actually know people and even talking to people that they might have come across socially or know, which is different than kind of most mental health services where, as a professional, we don't treat, acquaintances or friends or family members or things like that. But with peers, there is, you're working with the community you live with and associate with, but they're trained in confidentiality because they are doing screening. They are asking questions like the PQ2 and the CAGE aid, talking about their particular issues. And so they're trained also in maintaining the confidentiality of records. They keep kind of minimal list of names and contacts and referrals, and then some follow-ups on those referrals, and they're trained on how to maintain those in a safe place and keep their records here at the agency, and how to talk about other people's business and to not talk about their outreach with other outreach workers within hearing of these groups. And we've had a very good, I think, success rate with that part too. That they just know that they're not, they don't even gossip. They don't. They know the difference of when they're out socially and when they're actually working as an outreach worker. That helps answer that a bit.
It does. Thank you, Chris. And next question is also addressed to you, Ann. Work in an extremely conservative rural area. Do you have any suggestions in reaching GLBT seniors?
Well, we're not in a rural area, but it's pretty conservative here too. But I'll let Chris talk about that.
Well, it's going to take patience and it's going to take time. It's going to take it has to have peers, other GLBT people that you have, if there's any kind of gatekeepers or community informants that you can work with. It takes advertising, it takes outreach in finding the places where these people, GLBT community associates. And it may be, as a particular restaurant or club or bar, which in history have been traditional safe meeting places for GLBT people. It might mean some publicity that has some recognizable community symbols, like the rainbow we talked about, the pink triangle. We've learned is you have to be proactive. You just can't assume, well, we're a counseling agency, so everybody assumes that we're confidential and that we're safe and we accept people for who they are. We don't pass judgment. But that's not in mind of the person, especially the elder person coming to the services. They assume kind of the opposite, that I better be careful. They may not accept me for who they are. They might have had past counseling experiences where people did try to change their orientation or pathologize their orientation. So it has to be spoken out ahead of time that, no, we are a safe place. We accept you for who you are. We won't pass judgment. It's kind of looking for the community publications that may have somebody nowadays being on the internet to kind of search where the different community postings are about meetings or social groups. And just, we were kind of, we joked, and this is really just joking, but when we worked with that first group of outreach workers and trying to explain that indigenous leader model, we were talking a little bit about that gorillas in the mist movie and that image where you're just going to be kind of walking around the community and kind of peeking through the bushes and just watching where do GLBT elders congregate? Is it this coffee house? Is it this store or this particular bar or this particular restaurant? And just sort of listening, and then they picked up, well, there is a group that meets, at lunch at this restaurant, so why don't they show up at lunch at that restaurant, and just really kind of patiently kind of going into the community. But it also helps that when you work with peers in this indigenous leader model, often they will know where the communities are. And sometimes in the most conservative groups, and we do that here in Houston, even with some of the different subgroups, like different ethnic groups, like the Asian gay community, they're very much meeting just in private houses and kind of word of mouth and not going out into the community. So you really need somebody kind of from that group who's willing to train with you and then go back into that community.
And not just add that we've been around since 1978, and we have been pretty visible and vocal as much as we can on policy issues. We are involved in mental health networks, substance abuse networks, homeless networks. Chris is on the AAA Advisory Council here, and everywhere we go, we talk about GLBT elders and GLBT youth, and so everybody in town knows we're the place. And so they may send people to us, they'll tell people about us if they don't already know, but we have been around so long that it's pretty well known in the community that we're a safe place.
Our outreach workers, I think they told you they didn't realize when they were signing on to be an outreach worker that they were going to be hitting themselves. So the time we sent them to a group like the Elder Service Provider Network, meets with United Way, and they got up and introduced themselves as a peer outreach person for this GLBT program, realized that, well, I've outed myself, but they were talking month after month with all of the people out there, and eventually word starts getting around. We also have used some, as Ann said, some of our space here in our agency, offered it to the community for different kinds of meetings. So we have in our building here 12 LBT-specific 12-step programs that meet here, and then the word spreads that way. We have the gay, lesbian, museum and archives houses here and displays things. PFLAG, Parents and Friends of Lesbians and Gays, meet here, our teen program. Lots of other groups like that. Dignity, which is kind of a religious group for GLBT people. It's kind of just from all aspects trying to infiltrate the community a bit. But really getting out that message that when you come to us, it's also safe.
Thank you, Chris and Ann, for that answer. The next question is there a universal screening tool that anyone would share pertaining to general mental health, depression, and medication abuse?
This is Vivian at JFSLA. Well, I think the screening tools that all of us have discussed today are universal. I know that we've been using the PHQ-9 for screening for depression since first SAMHSA grant, and it's really embedded in the agency, and I think most, or not most, but many agencies, whether they are mental health or not, are using that as a screening tool for depression. And that's, available, no charge, etc.
Vivian, thank you for that. And that's something we could set out with the PowerPoint presentation and the recording to all the registrants for this webinar as an additional resource. Great. One of the questions came in about whether or not we're offering CEUs for this webinar, and no, we're not. We have just a few more minutes. If anyone else has any additional questions, feel free to type them into the chat box. I did want to let you all know that the next scheduled webinar that will be available to aging and behavioral health professionals across the country is scheduled for September 19, and the topic will be reaching and engaging older adults in behavioral health services. And the webinar is scheduled from 2:30 to 4 o'clock Eastern Time. And all who registered for this webinar today will receive the registration information for this upcoming webinar and other webinars. And some of the future topics for webinars are sustainability and financing, behavioral health interventions, and family caregivers as clients and partners in care.
Hi.
Yes.
It's me and Scheinholz. I apologize, but in the intro slides, I wanted to just mention that the Adults Technical Assistance Center, Older Americans Behavioral Health Technical Assistance Center, which supports the grantees as well as produces these webinars, also produces issue briefs, and I believe there's 14 issue briefs, 10 webinars, and also policy academy meetings in front of the 10 Health and Human Services regions across the country. The issue briefs and the webinars, I believe Alex showed a slide of places where you could find those, but I failed to mention that, so I just wanted to bring it up.
This is Alex. I'm not sure that was on a slide. We intended to, but they are available from the Administration on Aging's website on their behavioral health page, and also at the National Council on Aging's website on behavioral health page. So that's AOA.gov for behavioral health, or NCOA.org, and look for behavioral health. Thank you, Marion.
And with no additional questions, that concludes our webinar, and we look forward to having you all participate on our next webinar, as I mentioned, on September 19th. To all the speakers who presented today.
Thank you.
Have a good